All right, so can you go on to the next talk? Originally, Loïc Lang-Ladutsky was going to be here to talk about his series. He has a series of 100 patients who he's treated with intraoperative betadine therapy. Now, betadine is, as people know in the medical industry, is something we use to sterilize surfaces. So if you're going to do a surgical procedure, you can wash off the skin with betadine and sterilize it. But people, for a long time, surgeons in particular, for a long time have used betadine in bad situations. So if you have a bad infection, they kind of pour it into the area where the infection is inside your body. And sometimes when there's cancer, people have kind of poured it in there just to kill things. The interesting thing is that there really isn't a lot of data on betadine use. So when Loïc was going to come here, I was looking it up and kind of had an interest in kind of evaluating this, as we did in the lab. And so when Loïc had to, unfortunately, cancel from his trip, I decided that I could give part of the talk, part of his betadine talk, at least a background talk, and also cover some other ways of doing therapy intraoperatively. And some of the things that surgeons have used over years and has never really been looked at or analyzed, I decided that we could do in the lab, so we looked at some of these things. So betadine is one of the things that surgeons just do, and they think that it may help. There's really not a lot of evidence. People put in water because they think it lyses tumor cells. These are kind of the old wives' tales about what things can and can't do. And also, I wanted to address maybe in this talk the heated chemotherapy baths, the HiAcha and other things that some surgeons claim is useful during surgery, so that we can kind of look at all of those things. And I think there's some interesting results. Some of the things that really surprised me. So again, no disclosures. So we're going to talk a little bit initially about the HiAcha. It's called HiPEC in the peritoneum, HiAcha in the chest, and some other people have other names for it, but it's heated intraoperative or intraperitoneal intrapleural chemotherapy. And it's done at the time of surgery. And the idea is that when you have, again, the chest open, you can put chemotherapy in high concentrations inside the chest, so that instead of putting it in the veins where it's only a small percentage will get to the tumor, you can actually put it in high doses, and it should kill the tumor cells better. And if you heat it, there's some information that shows that if you heat chemotherapy, it can get into cells better, so it should kill things more efficiently. So this is being done, interestingly, clinically, without almost any data in preclinical models that support it, but it's been able to be done, and recently Dr. Sugarbaker presented his data on quite a few patients that suggests that maybe there might be some benefit. I also want to look at thermal therapies, because we found that this is actually a surprising thing that actually works quite well. So we're going to go over thermal therapies with hyperthermia, hypothermia, and also freezing or cryoablation. And then we're going to look at chemical things like betadine, hypoosmolar therapy, which is water, basically. And there's other ones that I'm not going to cover, but there's light therapy, photodynamic therapy. We heard a talk about that last year. And then immunotherapies, which we're going to talk about more in other talks later today. But there's some immunotherapy things like IL-4 toxin, mesothelin toxin. Those are toxins that are available potentially for research in mesothelioma, and also dendritic cell therapy and other antigen-based therapies. So Harvey Pass years ago looked at patients who he had resected within completely, like all gross disease, and then other patients who left a residual disease of more than 5 or 9 centimeters cubed. So I don't know how he measured that, but he estimated it. So basically what Harvey showed is that if you can resect more tumor, people seem to do better. Now, this is, again, not randomized, so it's hard to know whether that you're just selecting patients that will do better based on this criteria and that they will do better because of that. But it's hard to know whether you're actually affecting the survival. So the survival without surgery could have been exactly right in the middle. So again, this is that same picture. This is a complete decortication where you take everything out and you don't see anything left. So you know there's tumor cells here, and we actually do biopsies on patients at the end where we take a biopsy from here, from each lobe of the lung, from the diaphragm, from the different areas of the chest wall, and we try to assess whether there's actually residual tumor that we can see pathologically. And in our patients, roughly about 60% or so actually have negative biopsies in these areas, and maybe 40% have positive biopsies. So there's a difference there too. So that's the extent of disease in there. But basically, if we can do something to this with some kind of therapy that will extend the reach of the surgeon, then we can potentially eradicate the residual disease. So if we look at intrapleural chemotherapy plus or minus heat. This is from a review by Ann Tsao, who was here, I think last year or the year before, looking at intrapleural therapies and chemotherapy. Generally what she quoted was just selected perfusion studies, and this doesn't include the more recent Sugar-Baker one, but basically there's not much data is what this shows. Not reported, not reported, not reported, not reported. So really there's not a lot of data to suggest that this works, but it is done mostly with EPPs, but also with pleurectomies. And it's done with a variety of agents. These are some of the older studies, and the agents that were used were mostly platinum-based, but there are some of the other ones were not, like doxorubicin, were really older agents that don't really have a good response rate. So there's not much you can see in terms of survival, very little evidence, but if you look at the survival from the standpoint of relative to the other things I showed on the scattergram, these are basically the same. So there's really no evidence from any of these studies that she has shown that this does anything. And there's certainly, there was a study done by the Lung Cancer Study Group years ago looking at intrapleural chemotherapy, and it actually measured the serum levels of chemotherapy agents that were obtained, and they're basically, when you put enough into the pleural space, you get the same systemic absorption as you would as an IV dose, so the toxicity is potentially significant. This is the HiAcha experience from Boston. The HiAcha is just, I guess, the term that they want to use for it. It was a retrospective analysis of 103 patients. It was not randomized. 72 patients received HiAcha and 31 did not. And the only thing about this publication is it never said why. It said it was done at the discretion of the surgeon. So you never really know whether patients who got the HiAcha were in a different set. And in fact, one of the reasons why they didn't do HiAcha is because patients had received preoperative chemotherapy. Now, I don't know why they should exclude them from intraoperative chemotherapy, but they did. And when you look at some other data that we will discuss later, patients who got preoperative chemotherapy actually tend to do worse, if anything, than patients who don't, so who go on initial surgery. So these were not equivalent groups by any stretch of the imagination. And again, this decision to treat was basically on the discretion of the surgeon. And these are the two groups. So it looks like HiAcha patients do better. But again, in non-randomized trials, if you try to repeat these things with randomized trials, this could easily reverse. So it's really not clear whether there's really a difference, but it is intriguing. And you can see most of the follow-up is on patients are still within 2 years. There's very few patients out more than 2 or 3 years. So it's hard to know whether this is actually true, but the difference was substantial at 27 months versus 12.8 months. So it does give us an idea that maybe this could work, but we really need to understand it better. So what we did when we heard about this years ago, we said, well, we want to look at this and try to figure out why people are doing what they're doing, because when you look at the literature, people have done this in a number of different centers, and they've all done it a little bit differently. They use different chemotherapy agents, they use different temperatures, they use different times, and we wanted to kind of figure out what would be the optimal chemotherapy agent, what would be the optimal dose, time, and temperature, because those are all variables in doing this, and people just have kind of chosen randomly to do what they do. So the chemotherapy, again, one of the problems is low response rate, although theoretically it should be higher if you put high doses into the pleural space alone. It's only a single dose, so it's hard sometimes to follow up right after surgery within, again, 3 weeks or some other meaningful time period where chemotherapy usually is given to give another dose. But so you get a time period that goes by when you don't have any treatment, so it tends to recover. The tumor tends to recover. there is significant absorption. Dr. Ruch's trial that she published with the lung cancer study group did show that. So you do get significant things. And actually, Sugar Baker's group did find patients who went into kidney failure and were deaf afterwards because of the platinum agents that were used. So it does have significant toxicity. Sugar Baker, to this point, was using just platinum. You really probably need multiple drugs, just like you do with intravenous doses. So no randomized trials is a big problem. So what we did is we went in the lab and we took some tissue culture dishes and we started looking at different conditions. So this is a very, very busy slide, but what it's looking at is this is cisplatin chemotherapy alone into the pleural space, and we looked at different doses that were equivalent to what most people achieve with intravenous administration. And this was all done at 41 degrees, and I'll tell you that for a reason later, but we looked at different temperatures and we looked at different cell lines. So this cell line is a cell line that responds, it's a Chinese hamster ovary cell line that responds well to heat. So we use this as a positive control. MRC5 is a normal lung fibroblast line, so this is kind of a normal tissue control. And then A549, most people know, is a lung cancer line. And these other ones, H28, H2052, and MSTO cell lines are all mesothelioma cell lines. So it's I apologize for the busy slides. It's hard to show all this in a meaningful way together. But over the top of these things is different time points. So it goes from 0 time to 60 minutes of using these agents of cisplatin within the cultures. And kind of the only thing that you really need to kind of look at is that there's a slight decrease as time goes on with these bars, which is the hyperthermia effect. So over a longer period of time, the hyperthermia will have a decrease, or will decrease the viability of the cells, but it's minimal. It's these are log scales, so it's barely a 20% effect, even at 60 minutes. So it's not very much. So the hyperthermia doesn't really seem to have much of an effect, but the chemotherapy does, because if you look over the doses of chemotherapy, as the dose goes up, it does drop substantially. But again, this is 1 log, so most of the time you're not even reaching 1 log kill, even up to 60 minutes. So it's hard to know whether that will translate into actual clinical significance with a single dose. And this is pemetrexed, which in a similar manner, looking at all the same things, had basically a similar effect. The hyperthermia was basically nothing, just a little bit of decrement, and then the chemotherapy seemed to work. If you look at gemcitabine, another agent that's used very frequently, this is a little different because this is the time up here and the heat over here, so the concentration over here, so it's a little different, but I highlighted in red. The heat had a little bit more of an effect in this experiment, but again, the chemotherapy had a significant effect. Again, but it's less than 1 log kill for up to 60 minutes with high doses of chemotherapy. So the real question is, does that advantage translate into clinical effectiveness, which really is a big issue and really needs to be subjected to a randomized trial in the future to really clarify whether this potential toxicity during surgery is worth it to get a benefit. The other issue is the hyperthermia, which there's been some information that suggested originally that mesothelioma was a particularly thermal sensitive tumor. So some data that came out of a lab in Stanford, where I actually did research when I was an undergrad at Stanford, with different tumors, they looked at the thermal sensitivity. So they heated the tumor at 45 degrees for up to 120 minutes. And there were certain tumors that didn't respond well to heating, which is melanoma and cervical carcinoma. And there were other tumors that responded fairly well, which were ovarian cancer and mesothelioma. So these tumors appeared to be heat sensitive, dropping down, almost a log and a half in up to 60 minutes. So this is kind of what people initially got wind of. They thought, well, mesothelioma is a heat sensitive tumor. Now these were actually fresh tumor specimens. So one of the issues were that they didn't know whether these are actually tumor cells that were dying or other cells that were coming along for the ride in a fresh tumor specimen. So that wasn't really called out, so it's not clear whether there's actually any data to support that or not. So we went back and looked at some cell lines just with heat, and we looked at 37 degrees, 42 degrees, and 45 degrees. And one of the things clinically that's relevant is that you can rarely get patients' chests heated up to more than 42 degrees, mostly because there's a lot of blood flow going through the chest, so when you try to heat it up, the blood takes away the heat very quickly. So it's very hard to get local hyperthermia above 42 degrees, and if you can, people have found that there's a lot of complications, including thrombotic complications. People get a lot of thrombophlebitis. They get a lot of DVTs and PEs if you start to do that. So there are detrimental effects of going up to 45 degrees, but that's been kind of the standard, so we looked at that. And in the Chinese hamster ovary cells, you can see here that at 37 degrees, there's a good viability of all the cells. At 42 degrees, there may be just a little bit difference. And at 45 degrees is a big drop off in the cells. So these cells are very much affected by heating over a period of time of 20, 40, and 60 minutes down to very little survival at 45 degrees. So 45 degrees seems like that'd be something very good. And one of my projects when I was in this lab was actually looking at the temperature, and we found that anything below 43 degrees, actually the cells develop thermal tolerance simultaneously to heating. So unless you go above 43 degrees, oftentimes you don't see much of anything. So in the A549 cells, which are the lung cancer line, you saw a little bit at 45 degrees, a little bit of kill, but in the mesothelioma cell line, the H28, there's almost nothing. So this data would suggest that the mesothelioma cells are actually heat resistant. So doing heated chemotherapy doesn't necessarily make it work better. At least the heat doesn't do anything by itself. It still may have an effect in getting chemotherapy into the cells faster, but it certainly doesn't seem to kill tumor cells. At least at 42 degrees, there's really almost no effect. So if you look at 42 degrees, a variety of different cell lines, which we started looking at a bunch of things at 42 degrees only, which is the clinically relevant temperature that people are using. We looked at 0 to 60 minutes. And basically, you can see over here, these are the three mesothelioma cell lines. These are the controls. There is an effect on the controls, not great, but there is an effect. And in the mesothelioma cell lines, there's really nothing. So in multiple mesothelioma lines, there's really no evidence that hyperthermia by itself does anything. So one of the things we thought about is we thought, well, what if you go to lower temperatures? Maybe there's an effect of lower temperatures, and we went all the way down to basically 4 degrees. And this is the effect that you can see in Chinese hamster ovary cells of the heat. As you go higher, this is 45 degrees for 60 minutes, 40 minutes, 20 minutes, and then 42 for 60, 40, 20. And we kind of went all the way down to 4 degrees, and there's really no effect of cooling the cells. The lung cancer cells, same thing. Down to 4 degrees, there's just no effect. And here's some mesothelioma cells. None of them had any effect between 37 and 0 degrees. So if you look at this, only the really high temperatures at 45 degrees were of anything of real interest in terms of the data. One of the things we decided to do then was because of some clinical projects that were also going on, is to actually freeze the cells. So that kind of sounds well. You can freeze cells actually in a certain way. You can preserve them. You can thaw them out, years later, and they can still be viable. So we didn't know whether freezing would be good as a way to kill cells or not. But theoretically, if you freeze a cell in a way that would be amenable to killing them, they as you freeze things, water expands, and the water can expand and explode the cell. And there's some other reasons why I'll talk a little later about why this might be useful. So we looked at freezing the cells. We took these cells out. They were in a petri dish, and we put them into a minus 80-degree freezer for a variable period of time. So these are Chinese hamster ovary cells. These are control cells. And so we did for 1 cycle, 2 cycles, and 3 cycles. So what we did is we freeze it, let it freeze for a period of time, and then take it out, and then freeze it again, and take it out, and freeze it again, up to 3 times. If you do that for just 1 minute at a time, so 1 minute in the freezer out, 1 minute in the freezer out, you get only a little bit of kill. If you do it for 3 minutes, you get a reasonable kill. And if you do it for 5 minutes, it's much better. So freezing the cells actually seems to work, certainly almost as well as heating them to 45 degrees. This is the same effect for the lung cancer line, and mesothelioma seems like it's actually more effective. So if you freeze mesothelioma cells, they seem to be actually a little bit sensitive to freezing. They have higher water content. It's hard to know why. But if you freeze them even for 1 minute, there's a very low viability afterwards, which is interesting. And it's kind of, MSTO line is a little bit less sensitive. But then if you look at this kind of thermogram, we can call it, where you look at temperatures below freezing, this looks at temperatures for 1 minute, 3 minutes, and 5 minutes. So you can see that over this whole temperature range, the best effect of almost anything is in the Chinese hamster ovary cells is equivalent to 45 degrees, is freezing the cells for a very short period of time, 3 to 5 minutes. If you look at the A549 cells, the lung cancer line, it didn't work so well, the hyperthermia, and now actually freezing becomes much better effect, and it's done. Again, this could be done intraoperatively over 5 minutes versus 60 minutes for heating at 45 degrees. And if you look at the cell lines for mesothelioma, it's even become more substantial. The freezing seems to be much more effective than heating cells. So we looked at the different cell lines, and it was very effective. We got basically no survival in most of the time when you heat cells for 5 minutes in 1 to 3 sessions. MSTO is the same thing. So if you look at all these effects, basically the best temperature we'd predict to use clinically would be to freeze the cells. And so we're kind of in the process of clinically working on that to do that clinically. And this is kind of a composite thermogram kind of thing where you can, or thermal print, where you can see the effectiveness of various temperatures. And you can see that there is effect up here of temperatures up to 45 degrees for 60 minutes, but really at this point, this is 42 degrees, it really nothing happens. And so nothing happens until you actually start freezing, and then it happens quite dramatically. So this is some of the stuff that we've been using clinically for localized recurrences of mesothelioma. I'm not going to talk a lot about that, but the radiologists do have a method of freezing that's been around for years, from freezing tumors in the liver and other places. So we started using this to freeze recurrent tumor deposits in and around the chest. So this is really hard to see with the lights up the way they are, but there's an area here that in a PET scan that's yellow here. You can see this tumor nodule that gets treated, and unfortunately you can't see this, but when you treat it, it's actually very easy to monitor the treatment, because when you freeze the cells, the ice is expanding versus regular water, so it becomes hypodense on a CT scan. So you can actually see the ice ball as a hypodense area that freezes, and you can measure the ice ball versus where the tumor is. You can kind of make sure that you treat the whole thing. And afterwards, basically this whole area goes away. Even though it's a relatively big tumor, in a single treatment, we've been able to obliterate these tumors very reliably, and in areas that are actually very difficult to control otherwise. So here is a recurrence right at the base of the diaphragm, which is right behind the kidney here. And it's very difficult to control this with other methods, certainly, and chemotherapy is often ineffective. So you stick a needle in here in just a single episode, and then it just disappears, and it doesn't become a problem again. And we've actually treated, at this point, probably 150 or more lesions, and our control rate is around 90 to 96%. So these lesions are very well controlled. So if you have a localized area of tumor, the freezing seems to work very well, and there's been very, very few complications. This is just our series. Our actual early report was that we controlled 98% of all the tumor nodules that we treated. Now I just want to move on quickly in the last few minutes to chemical therapies and talking about betadine. Betadine, again, as I mentioned, is really kind of a thing that surgeons have used as voodoo kind of treatment oftentimes. It's an iodine solution. It's used for sterilizing skin, and water has also been used to kind of lyse cells. Water does lyse red blood cells for sure, but whether it lyses tumor cells or not is a different issue. So what we did is we looked at different concentrations of betadine. And I know that I talked to Loic actually, and when I started doing this, and he uses a 10% betadine solution. So he takes a betadine solution that we normally use for sterilizing things. He pours 10% of that into saline, and then puts it in the chest. And so what we did is we used, in these cell cultures, same things as before. Cell cultures, we started adding betadine. But we had to kind of backtrack because 10% was a little bit high. We had no survival with 10% betadine actually. So we backtracked down to 0.1% betadine, went up from there, and we got a pretty good dose response. So if you look at 0.1% of betadine, 0.5% up to 1%, there's really not much of an effect. You start getting to 2 and 3%, you get an effect. 4%, you get a pretty marked effect. It's almost 2 log kills, and at 5%, there's no survival. So at 5% betadine, it actually appears to kill. These are A549 cells, so the lung cancer line. You get even a more effect with longer times. That was for 20 minutes. This is for 40 minutes. If you let it stay in there for 60 minutes, like some people do for the heated chemotherapy, even the 4% betadine will kill cells, particularly when you look at it heating it at higher temperatures. But it's really kind of a very interesting finding. The mesothelioma cells have the same thing. 5% kills them, basically. And this, again, is a temperature curve. So at higher temperatures, it does seem to have more of an effect. But you can kill, even at regular temperatures, with just 5% betadine or anything more than that. And in 40 and 60 minutes, you get more effect at lower doses. So the effect is basically across all mesothelioma cell lines, the same thing. So basically, the more time, the more, and a little bit more heat up to a certain point, because again, you can see that 45 degrees is the one where cells start to die. So unless you go up to 45 degrees, the 41 degrees, which is what Luik uses, 43 degrees, 42 degrees some people use, just aren't very effective. So the heat doesn't add anything, and it can potentially add the toxicity of thrombophlebitis onto everything. This is very non-specific because this is an MRC5, which is a normal fibroblast line, so it's basically a non-specific killing. So it kills any cell that's there. But it's not necessarily a bad way to extend your surgical margins beyond that little bit of extra tissue that you need to get rid of the residual microscopic disease. So this is the MRC5. This is at 37 degrees, and it just shows, again, that the more betadine over here, the more kill, and at 5% betadine, there's really no survival. And they're all that way. So other therapies that I mentioned, light therapies I'm not going to cover. Immunotherapies are going to be covered by other speakers. There are cell-based therapies that we're very excited about, that we can actually put stem cells into the chest during the surgery that may potentially do things that will improve tumor control. We'll talk about that later. And so I think that from a surgeon standpoint, doing surgery on patients with mesothelioma is not very exciting. It's very tedious. It's a long operation. It's got minimal advantages in terms of patient survival. And I think the one opportunity that surgeons have to really make a difference in these patients is to really investigate more intraoperative therapies when you have the opportunity and you have the tumors exposed, and you can treat them with these things and hopefully in a meaningful way reduce the residual tumor. So basically, I think intraoperative therapies are really promising. A lot of things that can be done systemically can also be done intraoperatively, and they can reduce toxicities theoretically. So that's one of the reasons why we're interested in it. It's very focal and focused to where the tumor is. Like I said, only about a few % of patients actually recur distantly. So most of these patients are recurring at the edges of their surgical margin. So if we can extend the surgical margin chemically or with immunotherapy or with some other modality, we can actually make our surgery work a lot better and be more worthwhile. So we're looking forward to hearing about all the other talks today, immunotherapy and other things. So that's pretty much it.